and heterogeneous heterogeneous contrast enhancement is there. And this tumor was surgically exist, and NGS it turned to be the primary CNS neuroblastoma FOXR2 activated tumor. This is a new tumor described in the latest WHO 2024 classification. And this tumor was surgically exist, and this is the post radiotherapy prototherapy, and there is complete resolution of changes. And this is a similar case. We saw 2 years old child with a similar large cystic mass lesion with a solid cystic appearance and significant diffusion restriction. This also turned to be FOXR2 activated neuroblastoma. This type of tumor is latest 24 classified. It's a very new tumor, and usually they very few literatures are there, and there will be large cystic appearance with solid component and diffusion restriction of the adjacent bone developing and less edema will be seen in this type of tumor. Coming to the second case, this is on 10 years old child. We came across this. In this case, we saw there is a diffuse T2 appendix infiltrative lesion with the involvement of bilateral thalamus, and there are areas of raised diffusion in these lesions and some diffusion restriction. This you can see by the ASL diffusion eye diffusion. You can consider diffuse infiltrative pediatric type of glioma based upon the age. And this in this if it is mainly the brainstem, you can consider diffuse midline glioma. The midline it's both midline and hemispheric. And this case we thought as astricated 3 wild type, IDH wild type, new type of tumor. And this in NGS it turned to be RTK1 PTGR5 amplification type. The astric wild type and astric IDH wild type has 3 types. RTK1, RTK, and there's 3 types are there. This is the RTK1. And this is another case, which this also adolescent patient with left hemiparesis we saw. And this case, there was a diffuse infiltrative hemispheric lesion with diffusion restriction, and there was areas of raised perfusion. The lesion is extending from the surface of the prime, extending up to the ventricle. This type of tumor in adolescent age, we thought of hemispheric glioma, G34 mutant. This type of tumors usually this is a classical pattern with the diffusion restriction and raised perfusion can be seen. But usually in the early stage, enhancement may not be seen. This is another case. This is a 24 years patient with left hemiparesis. This is another case with a similar imaging appearance, the diffusion restriction perfusion. And this case, for some unknown reason, was initially thought as some other diagnosis in outside center, but it was referred to our center after 2 months back, 2 months later. And now it is showing heterogeneous significant aggressive type with a raised perfusion, diffusion restriction. This also turned to be a 3 hemispheric glioma. Another different type of pediatric glioma, some type of glioma, is a bithalamic type of lesions we saw. This both like this around 5 to 6 cases we saw. Both in these cases, the characteristic picture is that both thalamus are enlarged and very bulky we saw. And there are some areas of diffusion restriction. And these cases, all the cases we did biopsy, and this turned out to be EGFR exon 20 insertion glioma, a subtype of astricated altered midline glioma. It's an EGFR type 20 insertion glioma. We proved out. And this case, because it's important because the targeted therapy can be given in these cases. Some another new tumor is that this is one case of a patient with young patient with epilepsy, and there was and the CT we saw there is a cystic lesion with rim of calcification, and there is and it shows eccentric enhancing component. It was there in the lesion. This type usually we will think of ganglioglioma PXA this type, and this case surgery was done, and it is found to be polymorphous low-grade neuroepithelial tumor of the young plenty. This tumor is included in the latest 2021 classification. It is a pediatric low-grade glioma. The surgical excision is the curative for this type of tumors. This is another case, the infant presented with seizures, and in the CT we saw there is a large hemispheric lesion involving the one side of cerebral hemisphere with calcification and hemorrhage with less edema. In infant with this type of large tumor with calcification, hemorrhage, and less edema, we must think of infantile hemispheric glioma. This case surgery was done, and did NGS we diagnosed that is a type of NTRK type, infantile hemispheric glioma. There are many types of genetic mutation in the infantile hemispheric glioma, like NTRK, ROS, ALK, MET, like that. This is one type of NTRK altered. All these cases surgery was done and we gave a product therapy. And this is another interesting case, the posterior fossa tumor. This is a young child presented with a posterior fossa mass lesion, some diffusion restriction. And in this case, we did a brain and spine screening, and we saw there was diffuse leptomeningeal enhancement throughout the cerebral hemispheres and also throughout the spine. And this case, biopsy was done, surgery was done to remove part of the tumor, and it turned to be high-grade glioma, high-grade astrocytoma, high-grade glioma with pilot features. Glioma with pilot features. This also includes the latest WHO classification. Actually, pilocytic astrocytoma is grade 1. It's a pilocytic astrocytoma, anaplastic pilocytic. One term is there, but still it's not. Where the difference between this is not clear. High-grade glioma with pilot features. This is a high-grade type of pilocytic astrocytoma, high-grade types. This is another case, similar findings. This is one interesting case. Another case. This case initially presented in 2009 with a large mass lesion in the medulla and cervical spinal cord, and it is a well-defined lesion with significant enhancement. This case initially in 2009 it was operated and it was histopathology characterized as ependymoma, and it was treated. And after several years, patient had metastasis in the ventricle and in the suprasellar regions. And this re-excision was done. And now with the current classification, this was actually proved to be high-grade glioma with the pilot features. This is actually proved to be current classification. And this high-grade glioma are known to be can be indolent dose, and they are known to show ependemic and leptomeningeal spread. This another new type of tumor. This case is an infant 2 years child. It came to us, and this surgery was done for this case. And this case there was an extra-axial large mass lesion, solid cystic mass lesion with hemorrhagic level and significant enhancement and less edema. This appears to be extra-axial lesion. This type of lesion, this was a surgery was done, and this case turned to be intracranial mesenchymal tumor, FET fusion positive. This is also a new type of 2021 classification tumor. There are two types, one is CREB and CREB, and the prognosis is different between these two types of mutation. And these are usually can be extra-axial or intraventricular, and they usually will be a very large solid cystic type of lesions. This case or complete excision was done, followed by radiotherapy. But this case we saw there was a multiple recurrences in the dural based or all are dural based metastasis in the follow. This case again resurgery was done, and these cases and all again proton therapy was given. This is another similar case, two more case, similar diagnosis we saw. One more case with left parietal lobe enhancing lesion with significant raised perfusion. This also turned to be mesenchymal tumor, intracranial mesenchymal tumor. This is another case with the adult patient with the right cerebellar lesion. Actually, it was initially thought as meningioma outside and was treated. And the follow-up period we saw there was multiple dural-based metastasis. And this was surgery was done, and it is told to be intracranial mesenchymal tumor fusion possibly. This is another case we saw a lesion with posterior fossa mass lesion with a large cystic and multiple nodular enhancing lesion with some hemorrhages and diffusion restriction. Very unusual type of tumor in a young child. And this case we found out to be primary intracranial sarcoma dicer 1 mutant. This also a new type of tumor in 2021. Many of these tumors had there is no significant radiology literature how this type of tumors will appear. This is one more case of it's a different case, the intracranial mesenchymal chondrosarcoma. Chondrosarcoma, this type of tumor also can occur intracranially. And this case we cite this will be T2 hypointense and heterogeneous enhancement, diffusion restriction, and dural based with skull involvement. This is another new type of interesting tumor. In this case, we saw there was a enhancing lesion within the spinal canal, within the spinal cord, and similar lesion we saw in this case in the brain also. And this case, extraaxial lesion, extramedullary lesion within the dorsal or cervical or any location. One of the differential we must consider the endemic ependymoma. This case, whenever the usually ependymoma, you usually will be seeing the intramedullary. Whenever extramedullary location, spinal cord, we are seeing, we must consider one new type of tumor which is described in the 2021. It's the endemic type of spinal ependymoma, and these tumors will be more aggressive than the routine ependymoma cases. This is one infant presented to us with a large mass lesion within the less than 1 year, presented within the cella with a significant diffusion restriction and extensive leptomeningeal spread throughout the spinal canal. And this case, surgery was done, and surgery followed by proton therapy, radiotherapy was given, and there's complete resolution. But this case, the biopsy was proved to be pituitary blastoma. This is also a new entity in the latest 2021. And this is one rare case which we came across in the suprasellar region. This is an adult patient, the suprasellar location, large lobulated mass lesion with the T2 hypointensity, and there is homogeneous enhancement, some heterogeneity, and the pituitary stalk is not separately seen. This was previously described tumor, but it's not very rarely seen. It's a case of a granular cell tumor with the pituitary stalk with a very dark appearance in the T2 and heterogeneous enhancement with the pituitary stalk involvement. And this is one more case of the pituitary location. This also previously described, but it's uncommonly seen. This is a case of recurrent mass lesion with the cellular supracellular location with intense enhancement, and there is diffusion restriction, intense diffusion, and there is areas of raised perfusion. And this case, was proven to be pituitary oncocytoma. And this type of tumors will be more perfusion raised. This is another case, which is a tumor located in the young child. Young child presented with a large solid cystic mass lesion with calcification in the SW, and located in the lateral ventricle with extension to the third ventricle. And this type, and this is the routinely we may think ependymoma, craniopharyngiomas, like that of tumors. And this is the histopathology that of a cribriform neuroepithelial tumor. It is a new type of tumor, just provisionally included in the latest 2021 classification. This is another 45 years female patient which came to us, and this case we saw there was a heterogeneously enhancing mass lesion within the pineal region, and there was and the inferior part of the lesion shows heterogeneous enhancement, superior part shows homogeneous enhancement, and there is no diffusion restriction in this case. So it's less likely to be a black pineoblastoma, a germinoma. And this case, we don't know what's the imaging of the diagnosis, and finally it is turned to be the desmoplastic myxoid tumor of the pineal region, SMART B1 mutant. This is the latest tumor in the 2021, and there is no significant radiology literature about this type of tumor. And this type of tumors, many of the tumors we described in the latest, this edition will be coming in a few months. In this textbook, we have described many of these new imaging tumors. Coming to some of the new imaging methods we applied in our center. One is the amide proton transfer imaging. It will be available in very few centers. I think it may it's a old technique, but still it's not well applied in many of the centers. How this amide proton we used for one type of tumor, I will describe how this new imaging method we applied. These are some of the cases we saw in our center, and all these type of tumors have different imaging pattern. Usually one may think this is ependymoma, this is diffuse melanoma, astrocytoma, and GBM and granuloma. Usually many of them may think, but all these are turned to be pilocytic astrocytoma actually. The midline located periodic tumors, this all surgery, biopsy or surgery was done, and this all proven to be pilocytic carcinoma center. And this many of the midline tumors are not often biopsied, and the prognosis is completely different because pilocytic carcinoma has almost complete prognosis. There will be no mortality, and they will lifelong they will be there. But other type of tumors, what we thought are very poor prognosis. And also differentiation is important because pilocytic has molecularly targeted therapies. And one of the people with the imaging dilemma will be there. And we saw this some of the cases we saw. This is the same type of tumor with aggressive enhancement in the posterior fossa with the involvement of the medulla and cerebellum. And this is the ASL imaging method. This is the amide proton transfer imaging method. We saw there was significant elevated values in this type of tumors with very low perfusion in the ASL. We call the term ASL APT mismatch in this type of tumor. And this is the another case which I showed is the brain in the cerebromedullary junction lesion with similar very high values in APT and low values in ASL. This is the another case within the midbrain showing similar very high values in APT, low values in the ASL. And there's mismatch between the like this we saw many at least 20 to 35 cases, and all this pilocytic carcinoma we saw there was a very high values in the APT, but there was very low perfusion in the ASL. These are the tumors. This is another type of actually the large expansile mountain mass lesion with a similar imaging appearance. This is one type of tumor with usually we may think as ependymoma or aggressive type of any type of tumors. And this also showed APT, ASL mismatch. This all tumors don't repeat a pilocytic carcinoma. This is another tumor with the brainstem. And this area, in this case, we are not seeing a similar imaging appearance with low values in both imaging methods. This is don't repeat a diffuse malignant glioma. This is another type of tumor in the midbrain with raised perfusion and raised APT values. And this term will be in the ETMR, tumor with multi-layer process ETMR, it's a new tumor. So basically, we saw most of the pilocytic carcinoma, all the pilocytic carcinoma showed there was a very high values in APT. Based upon this method, we diagnosed its imaging biomarker for this type of tumor, and we published in the Nature Scientific Reports, and also we presented in the ISMRM. The ASNO and also ISNO awarded the option work in the neuroneurology this year for this paper. And coming to the next thing, it's a new imaging, but it's a non-contrast 4D non-contrast angiogram, 4D trans. This is also a new technique. This is a non-contrast 4D angiogram technique. In this, without contrast, we are able to dynamically we can occur, and the temporal resolution up to 160 milliseconds we are able to occur by this 4D angiogram. This is one of the cases of coordinate AVM. This is the frontal view of the dynamicity. I put like video like images also. This is the dynamicity of the frontal view, lateral view. You are able to see the AVM as well as the draining vein. Each of the phases, multiple phases we can occur. This is the same image. We are able to see the AVM with feeding artery, each of the feeding artery as well, and also the draining vein. And also we can occur by this imaging method 4D trans. We are able to occur the vessel selective also. Which vessel we want to track, that vessel also we can do. This is a vessel selective 4D angiogram of the right ICL. Like that, each of the vessels we can tap, and that alone, that vessel alone, we can you can see the outputs the supply. This is the right corded vein with reticular straight feeders and draining vein into the internal cerebral vein. And by this usually we apply this 4D angiogram for also post endocenter we do multiple moyamoya disease. This moyamoya disease as after surgery in the one side. This, we can see which antegrade flow, retrograde flow, and how is the collaterals, and how is the patency of the vessels. This is the left STA MCA post bypass. You can see to the STA the left MCA is filling, and retrogradely the MCA also filling. We are able to occur this type of images. Unlike CT angio, which is a static image or top angio, we are able to diagnostically. And also we usually follow AVM treatment, and this is some of the cases of one of the cases of RT post cyberknife. This is a pre-RT scan. You are seeing the AVM, And this is the follow-up, and each of the phases usually we won't follow up with the DSA. We follow up with the 4D tracks, and this is the post-RT scan. Follow we were able to see that after 2 years, after a year, 1.5 years, there is a complete obliteration of the nidus, and the draining way we are not able to see the draining way. And this similar some of them on interesting case with the AVM. AVM also usually will do functional fMRI and to see the localization of the leg area and areas and important areas, because to avoid these areas during the treatment. And this is the pre-RT one case with the large left frontal AVM. This is a pre-RT leg area and area, and actually the patient is moving the right hand and right limb, and the language and everything is a same thing. It's due to the plasticity, and after follow-up period, after treatment with cyberknife, and we are able to see that patient clinically improved, and the symptoms relocated to the some of the signals are relocated to the same site. Now bilateral representation is there. The plasticity with some improvement in the even the signals also we are able to occur. Coming to the another new imaging technique we released in our center is the astral challenge with this we did in our center many adult cerebrovascular disease with bypass surgery. It's one of the large center with revascularization procedures for not for mild, for adult cerebrovascular disease. And we published in this we described the how to do astrostomic challenge test with this is the case of usually IV assessment is not there in India. We do it with tablet astrostomic challenge, and we give tablets, and after an hour period we will take the images pre and post astrostomic ASL images. And we call it also we did some of the cases a contrast perfusion and 4D angiogram. And this is one of the cases with the left ICA recently 1 week before came. Patient is a case of left ICA occlusion, and there was a and 4D angiogram also there was only partial filling from there is a delay in the phases of filling, and there is the filling from the vessels from the right A becomes small, and there was paucity of vessels, and this is a pre-astrostomic ASL perfusion. And post-astrostomic, the normal state showed there was significant increase in the perfusion. It's a normal phenomenon. Whereas in the post-astrostomic challenge, the left cerebral hemisphere showed some areas are stable, some areas shows further reduction. This is a paradoxical response with the type 3 response, and these cases may require bypass procedures. This is another imaging method where we used is the connectome or cryptome imaging methods. And this is the in this imaging method, we need only the DTA images, and 3D T1 images. Based upon from this imaging technique, we can get multiple networks of the body, like multiple networks, and this will be very useful to the pre-surgical and post-surgical planning. Almost all the networks like people, language, all these networks we can acquire by this imaging method. This is one of the case 66 years female with the left frontotemporal mass lesion. This is the left temporal agreed mass lesion. This is the pre-surgery cryptome imaging method. We can acquire each of the networks, language, science, limbic occlusion, all these networks. And in this case, we did the pre-surgical networks and post-surgical networks. And we saw there was most of the networks are preserved except for the limbic network. In this network, some of the networks are breached in this case. So we can explain to the patient which how symptoms will be and what are the prognosis, everything we can explain. This is another case with the left insular grade 3 astrocytoma. This also we can see that each of the networks, how the networks are close to the lesion, and how the pre-surgical workup and everything will be useful. Coming to the treatment-related changes. Treatment-related changes post-radiotherapy. This is one of the topic that many neurologists are lacking in this, because many of the cases coming to our center will be seeing that will be misinterpreted as a tumor, as treatment as tumor. For example, many of the cases like oligodendroglioma treated with radiotherapy, and this type of oligodendroglioma almost it never recurs after radiotherapy. Very rarely recurs. So whenever you are seeing any treatment, any radiation any necrosis in the brain parenchyma, after follicular tumor, pilocytic tumor, you should not think as a tumor rather than the treatment. Just this one type of tumor is a corpus callosal tumor. Corpus callosal tumor. This is a post radiotherapy. There is a the tumor almost melted. This type of tumors will melt and significant response was there. But follow period, we are seeing some like some necrotic changes in the posterior corpus callosal. And this tumor actually this came from the UK and it was misinterpreted as the tumor progression. Whenever it's almost whenever necrotic type of areas you are coming as it has to be a radiation. Because we did ASL, APT, and CPV, DSC perfusion. All this method, it was hypoperfusion and low values. It was definitely a treatment rather than the tumor progression. And follow-up also showed the similar imaging appearance. This is another case. It's actually left temporal lobe astrocytoma. On the follow, this is the first follow. This the diffusion image is the first follow. We saw there was a diffusion resection, radiation, some necrosis in the corpus callosum. We did at this stage we did perfusion imaging and we there is a very low perfusion. We thought as a radiation treatment. And this also is an international patient carrying patient. And it was did a F18 scan, FDG F18 scan, and it was showing high uptake, and it was thought as tumor and outside center. And when follow period after a few months, we saw that there's complete disappearance of the treatment-related changes at the corpus callosum, and there was new changes in the other remaining left frontal lobe white matter. Actually, this also a treatment-related changes. This treatment changes are resolved, and new treatment changes occur, and we did perfusion in CPV and APT, all showed low values, and based upon usually we do this whenever combination of all this imaging method and then diagnosis. This is one more case of interesting case of the sinonasal carcinoma. This case actually referred as follow post chemo RT. There was a large necrotic mass in the right frontal lobe. Came to us as a tumor for radiotherapy, proton therapy, and we thought. We did perfusion imaging ASL, CBV, and all these methods showed very low perfusion. And the follow-up period, you can see that is complete disappearance of the lesion, complete disappearance even up to 2024. Whenever among all the imaging methods, ASL, DSC perfusion, these imaging methods looks like a gold standard for the radiation changes. Many of these cases will be treated with bevacizumab, that VEGF inhibitor, and during the treatment there may be increase in the diffusion resistance. This is one of the case of corpus callosum lesion, and post bevacizumab we saw there is increase in the diffusion restriction changes, and this also sometimes misinterpreted as a tumor progression, and this is actually a coagulative changes post bevacizumab, which is the normal phenomenon after bevacizumab. And also we make this new terms called radiation contrast enhancement, which may occur. This is called a type of small enhancement after treatment for glioma around the periventricular region. This is seen after the proton radiotherapy. It's called radiation contrast enhancement, and this type of enhancement will disappear without any treatments. We have seen many hundreds of radiation changes and tumor progression, and this type of in this imaging we did all the perfusion imaging, and ASL among this imaging method, ASL thought to be the best imaging method compared to the DSC and APT imaging method, and ASL also very much useful whenever there is a bleed within the tumor. This is one case of right temporal lobe glioblastoma. Follow period there is a new emerging lesion. And this case, this initial follow-up shows a focal small perfusion, and because of the hemorrhage, you are not able to see the DSC perfusion CPV. Whereas in the follow-up period after that, the lesion has increased, the perfusion also increased, and surgery was done. This turned to be the tumor recurrence. Usually in our center, we also do the T1 perfusion, DSC, ASL, and APT, but we avoid T1 perfusion because it's not followed universally. And also, we cannot compare the imaging done in the outside center also. And also we have done follow-up imaging for the meningiomas. For this is a case of meningioma with the treated with the alpha therapy. It's a type of treatment, nuclear medicine theranostic treatment when there is a progression after our treatments. And in this case, there was a tumor in the left temporal lobe and also tumor in the right parietal lobe. And this usually if there is any different difficulty in differentiating tumor or thing in meningioma, we can do dotapen because it is ability to the stomach structure in the meningioma. But in this case, we saw the ASL, this is the ASL imaging dotapen. The ASL imaging also matches with the dotapen, and it's also just ASL is just enough for differentiating the tumor progression for even case of meningioma also. Chordoma response. Many of the bone chordoma is one of the tumor which is the current treatment of choice in the proton therapy. The chordoma, we usually in the center usually see at least one or two chordomas per week, and the chordomas are after radiotherapy. The chordomas shows this type the main aim of the treatment is to arrest the growth of the chordoma and to prevent further compression of the brain parenchyma. Usually, there will be no change in the size of the tumor after radiotherapy. So there is a need for some imaging method to differentiate whether the actual response is occurred. So in case of chordoma, we applied the T1, that's a T1 perfusion or TSC perfusion, and this is a pre-surgery. This is a pre-surgery chordoma. This is after post-surgery, and this is the follow after proton therapy 6 months and 1 year. Any form of radiotherapy, when proton or any type of follow, we followed, and after a 6 months period, the T1 perfusion, the DC perfusion, the semi-conductive method, it has reduced initially and there is complete disappearance. This type of perfusion imaging and this T1 DC perfusion, that is a imaging biomarker to assess the response. And also we can use the K transform to be applied, and the curve also we can use, and we can see the shift in the curve and to assess the treatment response. We also do the intraoperative perioperative MRI. Is a perioperative MRI means that usually after surgery, the patient will be directly taken immediately after surgery. The patient will be directly from the OT to the MRI console, but it will be very cumbersome to keep the MRI machine empty, and immediately after surgery, the patient will be taken inside. And this is one of the case of PXA of the right temporal region. This nodule is a recurrent PXA. This is a cyst. This is a normal post-op cavity cyst. Initially, the surgeon went through the cyst and they removed multiple separations, but the tumor was left out due to some unknown reason because of the multiple separations. And we did the perioperative MRI initially. We saw the nodule was still remaining, and again surgery was done again the same day. And the follow-up, we showed the complete removal of the nodule. At least 30 to 40 cases of perioperative MRI will be done per year, and in this case, at least 10% of the cases require resurgery when perioperative done. This is another case of left temporal occipital lobe large mass lesion. Initial after perioperative MRI showed the anterior part is still posterior part is remaining, and again surgeon went, this complete removal of the lesion was done. And also when doing the imaging, many other centers still use the gradient type of imaging, that is SPGR type of imaging, but it's better to use the 3D T1 spin echo black light imaging. This because many of the tumors are we are able to pick up even 1 mm, 2 mm lesions with the black light imaging. The vessels will be suppressed, only the tiny nodules lesions will be picked. This is one of the case you are of metastasis. And metastasis, you are able to see the nodule separately in spin echo. Whereas in this case, black light imaging, this SPG gradient type of imaging, we usually will miss because the similar appears to the vessel. Because when the nodule is less than 4, only the nodules can be irradiated. When it is more than 4, the whole brain RT has to be given, and treatment management will be different. Coming to some other cases with the proton therapy also. This is one of the case series with the cranial we published with proton therapy or any radiotherapy. This type of tumors we saw. Initially, there is during therapy, the cyst of the craniopharyngioma may increase because of the increased intensity of the protein, because of the increased cholesterol, triglycerides, and after the follow-up period, this cyst we saw there is significant reduction. These are some of the cases. After proton therapy, initially there was this type of cyst show the protein the intensity of the cyst reduced and the cyst also disappears. Similarly, lack of time, middle blastoma also we saw imaging appearance. And also we saw after pilocytic carcinoma, pilocytic as I told, there was increased values in the APT, amyloid transfer imaging, the amyloid in the pilocytic carcinoma characteristically. After the therapy, many of the tumors may not reduce, actually may be stable or mild reduction, but we saw after therapy, we saw there is a progressive reduction in the APT values. This is the pre-proton therapy, this is the post-proton therapy. Pilocytic carcinoma, the amyloid proton transfer values actually significantly reduced. And this type of new imaging methods can be used for the follow-up response assessment. Actually, there will be no change in the diffusion coefficient, other imaging method, but in our case, it's only the APT showed there is a difference. Coming to some of the new symptoms that usually we may lack in finding that is a one type of is a young child. This is a young child, 8 years old patient with seizures. There is a right frontal lobe mass lesion, and and, and there was multiple subcortical lesions also noted in the bilateral cerebral hemispheres, in the frontal lobe, parietal lobes, and many of the regions. And this tumor alone showed very high perfusion and enhancement. This was surgically excised, and after the biopsy and the pathology, it was proven to be there was proven to be a high-grade glioma. And after that, we saw there was multiple subcortical hypertension. This type of multiple subcortical hypertension with one of the hypertension alone showing high grade. This is one of the findings constitutional mismatch triggers CMMRT. In this case, we did germline and it proved to be MSH2 homozygous autosomal recessive. Homozygous, that suggests that CMMRT constitutional mismatch repair deficiency. And this other type of tumor, other type of subcortical hypertension also can turn to be tumor related. This is another middle-aged patient with a diffuse infiltrative mass lesion in the frontal lobes, with some areas showing necrotic changes, necrotic changes. And this case also we did germinate, and it showed haploinsufficient pattern in multiple MSH, and this is known to be Lynch syndrome. And also some of the new type of metastatic spread, different type of metastatic spread, what we came across. This is one case of actually right parietal lobe IDS grade 4 astrocytoma, and this case and the follow period after treatment is a good response, but the patient had limb pain and there was a lesions in the limb, the femur, and multiple bone lesions. And this biopsy was done, and this turned to be the metastasis from the glioblastoma metastasis. It's a very unusual type of metastasis. And also we have this initial paper a few years back we published, and this case of glioblastoma with multiple leptomeningeal spread around the car. And this now we came across 20 to 30 cases with similar imaging PMS. Whenever the survival of the gliomas increases, and they tend to spread some other different type of patterns, like even spinal, bone, and we also saw some different patterns also. And this is one case of IDH mutant grade 4 astrocytoma. This was treated 2 years back, and patient was fine. But now, after two years of treatment, we saw there was a optic nerve thickening with raised perfusion. The remaining part of the tumor hypoperfused because of the treatment, but there was a focal thickening, and this is actually the astrocytoma spread to the optic nerve, which is very unusual. And this is another case with the right frontal lobe lesion with spread to the posterior fossa. Like this type of posterior fossa tumor spread to the posterior fossa cerebellar pelvis, we came across around almost 40 to 50 cases like this posterior fossa spread. This is still a very unusual spread, but the reason for this we are evaluating whether any tracks through the tract is specifically spreading, or what is the cause, because this site in the cerebellar pelvis classically spreads to this location. Many of the astrocytic tumors. And this is another case of temporal lobe glioblastoma with surgical tract spread with pre-auricular skin subcutaneous metastasis. And this is a very unusual, interesting tumor. Show the tumor. This is a case of this case came to us and MRI we did. There was a right frontal lobe mass lesion with heterogeneous pattern with heterogeneity and AT2 flare everything. And there was also two tumors. One tumor in the left insula and one tumor in the right frontal lobe. And both these tumors showed T2 flare mismatch. This tumor did not show. And very unusually, and all these type of tumor, all the tumors surgery was done, and this tumor prone to be oligodendroglioma. These two astrocytoma with T2 flare mismatch. It's a very unusual case with two different tumors within the same patient. Two astrocytoma, one oligodendroglioma. Coming to resting state FMRI also we started doing, and we are planning to incorporate in the even the radiotherapy planning. The resting state FMRI we can use because if you avoid the demon network, the cognition will be better. Some articles are quoting this. Coming to the DD, how to use this old technique in the multiple new tumors, multiple tumors, how to apply the DD. Usually we do the facial node schwannomas. We usually do the surgeon fill. We usually do the DTA tracking of the facial node and within the tumor because the facial node preservation is very important during the surgery. And this is one of the case of schwannoma with facial node. Facial node is located in the antro-inferior part. Rest of there is no nose. This is a post-surgery. Entire tumor was removed except the antro and this part. This is a post-surgery DTA. Post-surgery DTA showed the preserved fibers. The patient had a preserved function. And this type of detail we can use even for facial or like this, and it will be very useful. And also we can some of the cases of opticochiasmatic gliomas also biopsy or surgery will be planned. Around 10 to 15 cases we have done even for opticochiasmatic gliomas. Some cases we may be doing for the mutation analysis, BRAF mutation analysis, because targeted therapy can be given. And in this case of the DTA will be doing, and we can track the fibers within the optic chiasma region so that the safe area can be surgically and excised. Thank you. So these are some